Good afternoon. My name is Dr. Arslan Mahmood. I'm a family physician at Johns Hopkins Aramco, Tehran. As you're already aware, March is the month of colon cancer, and it's a pleasure to be talking about colon cancer screening program at Johns Hopkins Aramco Healthcare. Thank you very much for joining us, and I would urge everybody to hold your fire. Keep your mics muted, please, till the end. So I will take any questions, any burning questions you have in the end. So we'll go through why to bother about colon cancer screening first. We will look at the evidence for colon cancer screening. What are the risk factors for colon cancer? So we'll look at that. And what can be done to prevent colon cancer in the first place? What are the bases and the evidence of colon cancer screening? We will look at that briefly. And what options are available for colon cancer screening. So we will be talking about tests and the options available. So why bother with colon cancer screening program in the first place? Let's look at some statistics. Kingdom of Saudi Arabia. Colon cancer is the most common cancer among Saudi men. This is a study published in 2015. The same study looked at the prevalence of colon cancer among Saudi women, and it's the third commonest cancer. And 90% of colorectal cancers were diagnosed in patients who are 50 years and older. This is the data which is collected over a decade between 2001 to 2010 in the Kingdom of Saudi Arabia. And as you can see, incidence of colon cancer is rising every year. It's nearly equal prevalence amongst men and women. However, the rising incidence is down to many reasons. Majority of the attribute is attributed to improved colon cancer screening programs. Now, the story in the US is not very different. It's the third most common cancer in both men and women. In 2020, 147,950 new diagnoses of colorectal cancer were done. And unfortunately, 53,000 patients approximately will die due to colorectal cancer. 28,000 men and 24,000 women. Statistics from the UK are unfortunately again several thousand cases, approximately 42,000 over a 2 years period between 2015 to 2017. 16,000 deaths between 2016 to 2018. And the survival rate over 10 years was 53% when they looked at data between 2013 to 2017 in England. When they looked at it, around 54% cases were preventable with the help of colorectal cancer screening program. So in summary, colon cancer is one of the commonest cancer worldwide, and it's preventable. Now, let's look at what's the evidence behind colon cancer screening. I mean, does it really help patients? Let's look at some evidence. So multiple large meta-analyses looked at data over last few decades. And the findings were that between, I mean, if you compare how things were in 1970s and a few years ago, like 2017, chances of someone's dying from colorectal cancer are 54% less. They further dissected that data and looked at various reasons. Why is that there are less chances of dying now as compared to what they were in 1970? There were multiple factors. but the majority of the big reason was down to colorectal cancer screening program and improved treatments available for colorectal cancer at the moment. Another important thing is that we would like this cancer to be diagnosed early. If it's diagnosed locally, that means cancer is only within the, it's not invaded into the wall of the colon, it's local. The 5-year survival rates are impressive at 90%. If diagnosed at a later stage, when there has been a regional spread, that means the cancer has spread to the local lymph nodes, the 5-year survival drops down to 68%. And unfortunately, this figure goes down even further if cancer is diagnosed at a metastasis stage. So diagnosing colorectal cancer at an earlier stage is of paramount importance. The good news is that as of now we speak, there are more than 1 million survivors of colorectal cancer in the US. Right, so let's look at some risk factors. What causes colorectal cancer? Age is a risk factor, as I mentioned earlier. Majority of cases are diagnosed above 50, and hence this is the reason why colorectal cancer screening program is targeted predominantly above age 50. If your risk of colorectal cancer is average, obviously high risk colorectal cancer patients are screened earlier and much younger. Sedentary lifestyle, so no exercise, is linked with colorectal cancer. Large amounts of red meat and processed foods is another risk factor for colorectal cancer. Cigarette smoking, we know smoking causes many illnesses, and colorectal cancer is unfortunately again another one. And believe it or not, type 2 diabetes is linked with colorectal cancer as well. Obviously, family history of bowel cancer and non-cancerous growth in the bowel, and conditions like inflammatory bowel disease and certain rare conditions such as familial adenomatous polyposis or FAP, Gardner's syndrome, Lynch syndrome, and Peutz-Jeghers syndrome. These are rare conditions, they're not very common. Now let's look at, is it preventable? Yes, a lot can be done to prevent it from occurring in the first place. So studies look at different factors. If we modify those factors, how much risk reduction can be done? So this is relative risk reduction. If we avoid processed meats altogether and limit the intake of red meat, you can reduce your chances of getting colorectal cancer by 22%. Keeping healthy body weight, BMI of less than 25 is 27% reduction. It's a relative reduction. And if you are physically more active, 26%. Consuming whole grains, which are rich in fiber, and vegetables and fruits, which again fiber and antioxidants help you reduce the risk of colorectal cancer. Alcohol reduction leads to 8% reduction, and the biggest factor amongst all is stopping smoking. So if someone is a smoker, they can dramatically reduce their risk of colorectal cancer just by quitting smoking. Certain medicines also reduce risks of getting colorectal cancer. Aspirin is one of them. If patients take aspirin for about 10 years' time, their risk of reducing colorectal cancer is reduced by 40%. And statins, which are cholesterol-lowering medications, reduce the risk by 50%. So this is good effects of these medications on preventing cancers. And of course, if patients participate in bowel cancer screening program, we can really detect this condition early and hence reduce the risk of dying from it. Right, so let's look at how it's done. I'm sorry about this slide. This is just a simplified schematic diagram of our digestive system. Just a reminder from our I would say, grade 1 lessons. So the food from the mouth ends up in stomach, passing through esophagus. Then it goes into small intestine, later on to large intestine, which is also called colon. This is anatomically correct diagram of a digestive system. The part of the digestive system which is linked with high risk of cancers is colon, or the large intestine. This part of colon is called ascending colon. This part is transverse, and the descending colon, leading to rectum and anus. We know, we have understood now the natural history of colon cancer, that majority of colon cancer arrives as polyps growth in the intestine. Above age 50, colonic polyps are pretty common. Not all polyps lead to cancers of the colorectal. The types of polyps which we are worried about is something called adenomatous polyps and serrated polyps. So less than 5% of adenomatous polyps can progress to adenocarcinoma over 5 to 7 years. So this stage, which is benign pre-cancerous stage, lasts up to 7 to 10 years. Again, as I said, polyps are very common above age 50. Not all polyps progress to cancer. In fact, between different kinds of polyps, adenomatous polyps, less than 5% of them progress to this stage over 7 to 10 years period. Obviously, we would like cancer to be diagnosed at this stage or this stage rather than this stage. So what are the options for colon cancer screening? We can divide broadly colon cancer screening tests into 3 different kinds. One is the stool-based test, and endoscopic testing, which is also like a camera test, and radiologic testing. Stool-based test, there are 3 different kinds, 3 options we have available. The first one is the fecal immunochemical test. I'll be talking about fecal immunochemical test in a bit more detail, because that's one of the commonest performed tests for colon cancer screening. Then there are other options like guaiac-based fecal occult blood test. This is a relatively older method, and it's been overtaken by fecal immunochemical test. Multi-target stool DNA testing is the latest method. Unfortunately, this option is not available at Johns Hopkins at the moment as we speak. Colonoscopy is the gold standard in terms of screening for colorectal cancer, diagnosis, and surveillance. Sigmoidoscopy is a abridged version of colonoscopy, so it's only the descending part of colon, which is visualized with the help of this small scope. It's not widely performed. I mean, colonoscopy and fecal immunochemical testing remain the, I would say, the first choices. So sigmoidoscopy can be performed in a limited number of patients. Capsule endoscopy is relatively a newer method. Again, this is not a first-line method. However, this option can be performed. Benefit of this capsule endoscopy is that there is no risk of perforation, as there is no tube which is inserted. And unfortunately, the disadvantage is that you cannot take a sample. So to take a sample, you still have to perform colonoscopy. Computed tomography, colonography is another method, which I will be talking a little bit more detail later on. So let's focus on 2 main methods of colon cancer screening, fecal immunochemical test and colonoscopy. So both options are available at Johns Hopkins around. So what are the benefits of fecal immunochemical test? So it's a stool-based test. Patient performs this test once a year. It will be performed on a random stool sample. Patient will not be, it will not require any kind of bowel preparation. There are no dietary restrictions are involved. And if patients are taking thinners, blood thinners like aspirin or clopidogrel, they don't need to be discontinued. So it's generally speaking, it's a very convenient method of colon cancer screening. Studies have looked at patients' preference. Worldwide evidence suggests that patients prefer this method of screening, colon cancer screening. So it's obviously the best method of colorectal cancer screening which is liked by most patients, and the uptake is high because the test is no good. Doesn't matter how good the test is, if patients don't like it and it's not performed often enough, it will not be beneficial, unfortunately. As such, there are no cons of performing this test apart from taking your stool sample, which I would say minority of patients may dislike it. If this test comes as positive, the next step will be to perform a colonoscopy to further investigate it. So as such, there are no drawbacks, and there are many benefits, which are, as I mentioned, that convenience and no bowel preparation, no dietary restrictions, performed once a year, and we started at age 50 onwards. Now, let's look at the colonoscopy. So colonoscopy is a gold standard. As we know, this method has the highest sensitivity and specificity. So a tube is passed through the anus. It contains white light and camera. And there are other ports within the tube to take specimens from inside the colon. So this procedure is performed under sedation. A thorough bowel preparation is required. So the sensitivity and specificity of this test depends on bowel preparation. If the bowel preparation is very good, you get good results. If bowel preparation is not adequate, unfortunately, the procedure may have to be repeated later on. So a thorough bowel preparation is required. Normally, it's done 1 to 2 days beforehand. 2 to 3 days beforehand, certain dietary precautions are required, and a regimen of laxatives is followed. Patients follow that. Their patients are given full instructions that how they need to take their bowel prep. And on the day of the procedure, patient has to be accompanied by someone so that they can be taken back home. So bowel preparation by most patients is required, the inconvenient part. Some patients, not majority, but some patients may remember experiencing pain, discomfort, bloating, abdominal distension during the procedure. There are minor risks involved with sedation. Patients are sedated. They're not given general anesthesia. They are sedated, so there can be small risks involved with sedation. The main risk with colonoscopy is a risk of bowel perforation. So the studies confirm that the rate of bowel perforation is anything between 2 to 5 per 1,000 performed procedures. This risk dramatically goes up if patient's age is high and there are other comorbidities. So age 75 or age 80 plus, generally speaking, we don't perform colonoscopy, colorectal screening at that age, but there may be certain patients who require this procedure. So the risk is highest in that age group, and studies confirm at age 75 plus, the risk is as high as 50 perforations per 1,000. So bowel perforation can lead to hospital admission. And unfortunately, most of these bowel perforations are treated as inpatients. Risk of dying from this procedure is extremely low. So it's 0.0007%, which is extremely low. Radiologic testing is another method we use. This is not considered as a first line. Patients where there are contraindications to colonoscopy. I did not touch the contraindications to colonoscopy. So there are certain situations where colonoscopy should not be performed. Most of those situations when patients will be unwell, and the chances are they will be admitted to a hospital. So there are certain situations where colonoscopy is either contraindicated or it's not performed or is not considered safer, and alternative methods of imaging are used. So as I said earlier, the stool-based test is just a stool test once a year. Endoscopy, which is mainly colonoscopy, is performed every 10 years if it's normal. I will come to that in the end, like how often it should be performed and how all these different procedures compare to one another. And CT colonography, which is computed tomography. So that means it's like a CT scan. So most of you would have heard of CT scan, which is an X-ray based investigation. So there is radiation involved. Patient has to prepare, just like for colonoscopy, they need bowel preparation, and slices of CT scan are taken along with other imaging, 2D and 3D imaging techniques to reconstruct colon. It's pretty good at picking up lesions like polyp and early cancers. However, there are some, obviously, the caveats with this procedure is that I will discuss it later, that the survival benefits are less as compared to the fecal immunochemical testing or colonoscopy. And the other caveat is, as I mentioned, bowel preparation, risk of radiation. So there is significant radiation which is involved during this procedure. It's the whole abdomen is exposed to radiation, and the risks of incidental findings, because there are certain findings when we do a CT scan, let's say in liver, lesions in liver, or sometimes in pelvis, which are most of the times benign, unfortunately may cause anxiety and may require further imaging or investigations to be confirmed that they are benign. So there is risk of incidental findings, unfortunately, with this procedure. Right, so this will be the last slide of this presentation. I know this slide looks very busy. I will spend some time on it and dissect it for you. So this slide is comparing, this is like a summary of this whole presentation. Let me give a simplified statement first and then discuss it a bit more detail first. I would like you to focus on colonoscopy and fecal immunochemical test, the stool test we were talking about, once a year stool test we were talking about. So let's focus on these two methods only. Let's forget about the rest for now. So colonoscopy versus fecal immunochemical testing. Between these two, let's focus on two parameters only. One is this purple bar you see, and the other one is these numbers. Purple bar is the sensitivity of the test. So what is sensitivity? What is specificity? Sensitivity is good at ruling in a disease, while specificity is good at ruling out the disease. So what it means is that sensitivity of a test, how good the test is at ruling in a condition or a disease, and specificity of a test is how good a test is ruling out a condition. So sensitivity is very obvious that colonoscopy has much higher sensitivity as compared to fecal immunochemical testing. So the purple bar is colorectal cancer. So we are focusing on colorectal cancer only and the sensitivity of these two tests. So on surface, it might appear, wow, colonoscopy is much more, looks like very good actually as compared to fecal immunochemical testing. But when we look at these numbers, that yes, colonoscopy diagnoses more cancer than fecal immunochemical testing. But does it really matter? I mean, the ultimate marker, or I would say the ultimate parameter, which we are really bothered about, is how many lives does this test saves? So does it really reduce risk of dying from colorectal cancer? That's the ultimate parameter. So these are the numbers. So it says that if you perform colonoscopy properly, so a good prep performed as advised by the doctor, so 22 to 24 lives out of 1,000. So if you screen 1,000 people, 22 to 24 can be saved due to this colonoscopy. And if you look at this fecal immunochemical test, it's pretty much same. So 20 to 23. So there's not a big difference between these two. Yes, it's slightly better. However, this is not too bad, I would say, so as compared to colonoscopy. So in terms of reducing colorectal related mortality, fecal immunochemical test, which is a very convenient test, performed once a year, the uptake of this test is very high, has more or less same benefits to colonoscopy. So that's the summary I would say. No doubt colonoscopy is the best. Fecal immunochemical test is almost as good as colonoscopy in terms of preventing colorectal cancer deaths. The other methods, obviously, now if you can go in a bit more detail on the slide, that these columns, like the purple one represents colorectal cancer, green for adenomas, which are larger, blue one is the adenomas, which are medium size, and this peach color bar represents smaller size adenomas. So it's not a surprise that colonoscopy, which is a camera-based test, so you can visualize the colonic wall, is much superior as compared to any other test, and far more superior than fecal immunochemical test in terms of diagnosing these precancerous lesions. So the precancerous lesions, there is no doubt about that colonoscopy is much superior at diagnosing as compared to fecal immunochemical test. Remember, as I mentioned earlier, these polyps are pretty common after the age of 50, and not all of them progress to the cancer stage. In fact, less than 5% of them will progress to the cancer stage over 7 to 10 years time. So yes, it's very good. I mean, if you look at CT colonography, I mean, unfortunately, it does have a bit poor colorectal cancer death reduction rate, and hence it's not, I mean, it can be used, however, it's not considered as a first line anymore. So as of the latest recommendations by American Academy of Family Practice, they do not recommend CT coronography as one of the first methods of colorectal screening. Sigmoidoscopy, unfortunately, I mean, in certain patients who cannot tolerate any of this can be performed. I mean, there is not, I mean, the cancer-related death reduction is as good as CT colonography. So GWAG, fecal occult blood test, we used to do it before at Johns Hopkins Aramco. We don't do that anymore. This test has been overtaken by FIT testing, so fecal immunochemical test. There were many caveats of GWAG fecal occult blood test. Patients had to drop 3 samples. There has to be certain precautions taken 3 days before, certain restrictions, dietary restrictions. They have to be taken before performing this test. So this test is not in fashion anymore. Now, perhaps this is the future, which is, as I mentioned earlier, this is a multi-target stool DNA test. So what it does basically, it looks at cancer mutations which are found in the stool, and it combines this test with fecal immunochemical test. So this is like best of both worlds. So it's also looking at the mutations which are happening in the colonic wall, the lesions, the precancerous lesions, and the cancer itself, and also fecal immunochemical test is combined with that as well. So not a surprise that this test, in terms of sensitivity, is as good as colonoscopy. So the sensitivity of this test in terms of picking up colorectal cancer, it's brilliant. And look at the convenience it has, and no bowel prep is needed, just a random stool sample. So this is performed every 3 years, so it's very convenient. Unfortunately, it's not available at Johns Hopkins at the moment as we speak, and even in the US, it's not like a widely accepted method. However, it may become a method of choice, I would say, for colorectal cancer screening. So options at Johns Hopkins Aramco, we have colonoscopy available. We have this weekly immunochemical test available. It's a shared decision process. So patients are involved in this decision-making process. What I would urge everybody who's above age 50 is to make an appointment with their primary care physician and to discuss the options, what options are available, in terms of would they prefer colonoscopy or FIT. So it's a shared decision-making process. Every person is different, so the decision has to be customized for that person. The risks and the I would say the benefits need to be discussed on case-to-case basis. I would say for most patients, this will be a method of choice. Some patients may opt for colonoscopy, which is perfectly fine, and they have the option available at Johns Hopkins Aramco. Somebody who is at high risk of colorectal cancer, as I mentioned, certain medical conditions, so family history, certain medical conditions put you at high risk of colorectal cancer. So there are different protocols which are followed. And in terms of colonoscopy, how often it is performed. So for if it's found to be completely, if the colon is found to be free of any polyps, this is performed every 10 years. So this is like a normal interval between the colonoscopies. So this interval can be reduced anything between 3 years up to 10 years based on the findings of the colonoscopy. So what matters is the kind of the polyp. So when we find a polyp, that polyp is taken. So that procedure is called polypectomy. The sample is sent for histopathology and it's analyzed under the microscope to confirm what kind of polyp is that. So the type of polyp matters. How many polyps are found? So, 1 to 3, 3 to 6 or something. So how many polyps are found during the colonoscopy? And also the size of the polyp. So these 3 parameters we look at: type of the polyp, size, and number of the polyps. And that's how we decide how often the colonoscopy should be performed. So this recommendation normally comes from the gastroenterologist who advised patient that the next colonoscopy should be done after these many years. Right, so I think we're pretty much done with this. So thank you very much, and thank you for joining us this afternoon. Now I will open the forum for any questions you may have. So please feel free to unmute your mic and ask any questions if you have any. There is a question from the audience. I was thinking of taking the test at age 37. Do you recommend? I would suggest that below the age of 50, I would really urge you to arrange an appointment with your physician. So, as I said, this decision of testing needs to be taken on case-to-case basis. For majority of the patient, those who are average risk, the interval of screening will be, the starting age for the screening will be age 50 onwards. There are certain conditions, as I mentioned, colonoscopy is performed early on in life. So If you feel that your risk of colorectal cancer is high, or if you have any family history of colorectal cancer or certain medical conditions, I would really urge you to arrange an appointment with your primary care physician and discuss it, discuss your concern with him or her. Thank you. So ladies and gentlemen, thank you very much for joining us this afternoon. I will wait for another 5 minutes if you have any questions, and we will close this event. So let's review the risk factors again. Sorry, there is a question from the audience. So there's a question about from the audience on why the cancers are rising in Saudi Arabia. So I think this question refers to my earlier slide. That's so it's not Saudi Arabia only where the cases are rising. This is a worldwide trend. Multiple factors are involved. I mean, you can look at, this question can be asked, this question can be asked about any other medical condition as well. For example, diabetes mellitus. So we look at like, why is that the diabetes mellitus is rising, the incidence and prevalence is rising so dramatically. There are multiple factors. A lot of it is to do with our lifestyle. And of course, is to do with that we diagnose cancers early and we treat them. So it's to do with our lifestyle. So the changing patterns, like the sedentary lifestyle, many of us are doing office jobs, not doing enough physical activity, our eating habits. So unfortunately, as compared to what it used to be, let's say a few decades ago, the diet is rich in processed foods, salts, and many more people have conditions like diabetes, which is again a risk factor. And unfortunately, the prevalence of smoking in Saudi population generally is very high. In the West, prevalence of smoking is going down, while here it's still increasing, unfortunately. And amongst the, for example, Chinese population as compared to West, the prevalence, the incidence of somebody starting like a new smoker, that incident is going dramatically high up in condition, places like China and India. So there are multiple factors involved here. So as I said, lifestyle, and also to do with better surveillance methods. So obviously, if we're going to do tests, that means we will find new patients as well, clearly, so there will be new diagnoses every year. If patients start taking up, start participating in the colorectal cancer screening program, and if majority of them they're doing it, clearly we will see a big rise in the number of new cases for that year when the uptake becomes high. In the past as well, it's been looked at, for example, there are obviously surveillance programs for PAPs, cervical cancer and also breast cancer as well, apart from colorectal cancer. So it's been seen in the past that when somebody important, let's say a celebrity, is diagnosed with a serious condition like cancer, that year, the public perception, the awareness and everything is dramatically goes up. And the uptake for all these screening methods and the demand for it suddenly goes up because patients become more aware of it. Hence, they consider that as a priority. And hence, we may see more number of cases for that year. So there are many factors which determine why the cases go up. So that was a very good question. Thank you for that. And I can just review again. I would say, where as a primary care physician, I really believe in prevention. The disease should not happen in the first place. And I really believe that these things really work. So we should really, all of us should really we should avoid processed food completely. So there is a big trend, salami, sandwiches, and processed meat, ham, all of that is consumed in large amounts. Unfortunately, this trend really needs to stop. So avoiding processed meat should be our priority. And red meat is consumed, especially in Middle East, in larger amounts, which really needs to stop. If it's not stopped, at least it should be limited. And BMI, again, unfortunately, as I said, mentioned, obesity is a big risk factor. Physical activity. A typical Saudi diet is really lacking in fruits and vegetables and whole grain pulses and all that. People don't eat vegetables and fruit as they should really be eating here. So this is another big factor here. Our diet is not so good here. Alcohol is not a big factor here, but again, it matters. Smoking is a big thing. So patients really need to make it a priority to quit smoking. So at Johns Hopkins, we have a help available. So we have smoking cessation clinic. We have counselors available. Patients can arrange an appointment with the smoking cessation clinic. Counselors help them to quit. Obviously, patients need to make up mind and they need to decide that they want to quit. Nobody can help patient to quit smoking if they don't want to quit, simply. When they want to quit, however, help is available. So counseling is there. Also, there are medications there which can increase the chances of patient quitting it for longer. So the help is available. I would really urge everybody who is a smoker to really make it a priority for 2021 to stop smoking. This is obviously an incidental thing, aspirin and statins. So a lot of patients are taking statins due to different reasons. So either they are diagnosed with dyslipidemia or they were diabetics and they were started on statins. And this is I would say a side benefit. Obviously, statins are not given for this reason primarily. They are not licensed for this thing. However, it's been found that statins reduce the risk of colon cancer. So there was a lot of debate about aspirin being used to prevent colon cancer. Again, in the past, let's say going back 5 to 10 years, there was a general feeling among the physician that anybody who turns 50, they should take aspirin for cardiovascular benefits. So that's the main reason why aspirin is used, I would say, in majority of patients. However, and aspirin is licensed for that. However, aspirin is not licensed to prevent colorectal cancer. Now, this dramatic reduction in the risk of colorectal cancer may be beneficial and may be considered in certain high-risk patients. Obviously, aspirin has its own disadvantages. There's a risk of bleeding. Bleeding can be major, which may require endoscopies or hospital admission, unfortunately. So That risk needs to be again kept in mind, and this decision whether aspirin should be used as a primary prevention for colorectal cancer again needs to come from like it needs to be a shared decision between patient and doctor, and it needs to be a shared decision on whether it should be given or not. So generally speaking, aspirin is not promoted for this purpose only, but somebody who is at, let's say, high risk of cardiovascular disease, or a medium risk of cardiovascular disease, but also there is some risk of colorectal cancer as well. Aspirin can be beneficial for both things. So, you can actually hit two birds with one stone. So, that would be ideal in that scenario. But again, as I said, this decision needs to be taken case to case. It's a very personalized decision. As we know, one size does not fit all. So this approach should not be used. So it needs to be a very personalized or customized decision. And I would really urge all of you who has attended today that consider a bowel cancer screening program, or if you have relatives, friends, parents who are above 50, encourage them to participate in this program. Patients are apprehensive about endoscopies, colonoscopies, because it's a procedure done in a hospital setting. There are some risks with it. The risks are generally speaking very low. They should at least do this annual test, the stool test, which is ordered by the primary care physician. I would really urge everybody to participate in them. So as I said, both options are available, colonoscopy or the stool test. We promote stool testing because patients like it. However, it's a patient choice. So this decision needs to be, this needs to be discussed with your primary care physician. Any more questions? So I would like to say thank you again to all of you who has attended on a Saturday afternoon, taking time out, and thank you very much. If you have any further questions, you can email me. Just written my email down.